For years, many people thought that type 2 diabetes treatment follows one simple path. We check your A1C and we start you on metformin and then keep on adding more medication as the disease progresses. I've been a physician for last 30 years and the management of diabetes has changed significantly. I remember in my training days, we had only three medications: metformin, which was just introduced to the market. Second was sulfonylureas. You may remember the medications like chlorpropamide, glyburide, glipizide, and insulin. And the goal and the understanding at that time was lower your hemoglobin A1C no matter which way we could accomplish. But in 2026, the treatment guidelines have changed because we have better medications which we can use to protect your brain, heart, kidney, liver, and prevent the complications like heart attack, stroke, and death. Why is important to lower your blood sugar? Blood sugar, when it's higher than normal, is like a liquid razor blade, and it is sanding the inner lining of your blood vessel, which are endothelial cells, which produce local injury and inflammation. Then the cholesterol comes in and get deposited underneath it, and your blood pressure provides the shearing force to make this damage worse. This is the simplest model with which I could explain you why it's important to control your blood sugar. Based on current guidelines of 2026, according to American Diabetic Association, now we treat your A1C, but we take comorbidities into consideration. We look at your weight, we look at your kidneys, we look at your liver, and we could look at your heart, and we could tailor which medication which we are going to use as a first line treatment rather than starting with a fixed logarithm, starting with metformin, adding one medication over the other. Now, the goal in 2026 is to protect your heart, kidneys, make you lose weight, protect your liver, and of course, lower your glucose. Metformin is a still very, very important medication. But the message is alone metformin is not enough. I'm not preaching that the metformin is not working or is not needed, but message in 2026 is that in addition to your goal of controlling your blood sugar and hemoglobin A1C, we need to use the medications which will protect your organ system. Stop treating just A1C because that's the fallacy. If I could lower your from 8 to 7 with metformin, but you already have heart failure, and I use a class of medication, SGLT2 inhibitors like Jardiance and Farxiga, I not only lower your sugar, but I protect you from getting worsening of your heart failure. That is, so we could tailor the medication for your cardiovascular health, your heart failure, your chronic kidney disease, your liver disease, and above all, these medications are very, very safe. Chances of hypoglycemia, meaning low blood sugar when your sugar is not high, are very, very low. Medication burden definitely is changing and improving. We are not treating hemoglobin A1C now. We are treating you as an individual with your individual risk factors and help you improve your risk factors and prevent complications. Where does metformin fit in 2026? Metformin is not obsolete. Remember, the sugar in your blood comes from two sources. One, what you consume. Second, what your liver makes out of stored glycogen and also converting proteins into your glucose. Metformin stops that process, and that's very effective. You might, if you are a diabetic, you might have had experience. You wake up and your blood sugar is high. This gluconeogenesis, meaning converting your glycogen into sugar and converting your proteins into sugar, may be in a play. Your doctor will guide you, and metformin definitely has a role. This medication is inexpensive. So long as your kidney functions are well, it is very, very safe. And it does not lower your sugar unless very high. So then also we are looking at if you have already established heart attack, stroke, and how we could prevent all these complications, because two classes of medications are really the treatment of diabetes. All these medications are helping to change at a cellular level. They are fixing the pathology not only to control your blood sugar. SGLT2 inhibitors like Farxiga and Jardiance, they are also revolutionizing the heart failure treatment. Now they are a permanent part of the medications of drug. If you have heart or kidney disease, which medication you should be on? If you already have a stent in the heart or a bypass or a heart failure, or your doctor has told you you have stage 2, 3, 4 kidney disease, your choice of medication change. If you have heart problems, you should be on GLP-1 agonist, and if you have heart failure, you should be on SGLT2 inhibitor. We are treating diabetes as a metabolic disease. Once you're overweight, you develop insulin resistance, your sugar start creeping up, your hemoglobin A1C start creeping up, your 2-hour glucose tolerance test start becoming abnormal, you develop sleep apnea, and your body is at risk to develop fatty liver, heart attack, stroke, and death. And obesity not only give you these chemical problems, it also affects you mechanically. Your joints start giving up, you start developing back pain, knee pain, hip pain, ankle pain, foot pain. So these medications are very effective. That is where the beauty of these medications lies. These medications go to the core of our problem. They go to your brain and prevent this constant craving of food. That's exactly the underlying fundamental problem which we are dealing with. Liver disease has entered into a diabetes decision tree now. We used to think in the past these being the isolated parts. Now we know they're part of the same metabolic process which is giving you heart attack and stroke, kidney problem, and fatty liver leading to inflammation. It is the metabolic process same which is causing you to develop liver problem. Liver is now part of diabetes treatment conversation. If lot of studies are showing again, you lose weight, your obstructive sleep apnea improves. Technology is moving earlier. CGM is not just for insulin dependent diabetes. This is one of the most painful things which I go through every day. I know for a fact when I put people on CGMs, even when they are not requiring insulin, the constant feedback of their eating behavior has led to significant improvement on their day-to-day health and day-to-day eating pattern. They don't drink soda anymore. They don't drink juice anymore. They can understand the combination of foods which they could eat which does not move their sugar. They become their own food scientists. Unfortunately, in spite of ADA recommending it, health plans still do not cover CGMs for everybody. You need to be on insulin or you need to have a complicated treatment where you are at high risk to develop hypoglycemia. That is the only they will cover. But If you are using CGM, you will be able to monitor how your mean glucose is, and you will be able to know your index, and you could predict your hemoglobin A1C. And further, now the meters are getting smarter, and they can protect you from developing hypoglycemia, because now they will warn you even before your sugar is falling down. I think it is a beautiful time where technology, new medications are going to the core of the problem and helping us to control your risk factors, prevent complications. So now in 2026, the diabetes treatment logarithm is as follows. First, diabetes and establish individualized goals. Lifestyle remains foundational, meaning eat correctly, physical activity, sleep, weight management, stopping smoking, and everything in your capacity to decrease cardiovascular risk factors. Second, ask, does the patient has already established atherosclerotic heart disease or is at high risk to develop atherosclerotic heart disease? None of these conditions now are treated in isolation. We must consider the overall risk. We must have a comprehensive plan to lower your A1C, prevent hypoglycemia, make you lose weight, manage your side effect. Cost, access, and patient preference still remains the issue. I hope I have made a case that once you are being treated for diabetes, talk to your physician, get your risk individualized, and know your diagnosis and get the best medication for that comorbidities. Like, share, and subscribe to our channel Kundlas MD. If you have been here up to this point, I have linked this video, and I know you're going to enjoy being more thorough and learning about prediabetes. Thank you very much.